Welcome back everyone to another episode of Anaesthesia Overview video presentation. Today we will be discussing a variety of intravenous anesthetic induction agents. We will be looking at the different types of these agents, the uses, properties and characteristics, as well as the side effect profiles of each of these induction agents. Let us first now take a look at Propofol. It is a lipophilic phenol derivative and is produced commercially as a white emulsion in soybean oil. And it has become the most commonly used IV anesthetics induction agent in the developed world. It works by increasing GABA-mediated inhibitory tone to the central nervous system. Propofol decreases the rate of dissociation of the GABA from the receptors, thereby increasing the duration of GABA-activated opening of the chloride channel with resulting hyperpolarization of the cell membranes. Propofol has a rapid onset of action due to rapid distribution. It has a half-life of about 30 to 60 minutes and with good recovery after the induction. It also has a proven anti-emetic properties, which may be due to the direct suppression of chemoreceptor trigger zone, which is involved in initiation of vomiting. Propofol is suitable for induction and maintenance of general anesthesia, as well as sedation during regional anesthesia and even short procedures. With its advantages, it also comes with its disadvantages. It has a risk profile of cardiorespiratory depression, hence it is often contraindicated in the extremes of age. Besides, it is also contraindicated in the case of egg or soy allergy. One last important thing to note, the ampoules containing the propofol have to be used or discarded immediately once it's open, as it is a high risk of bacterial growth. Next up, we have Thiopenthal as the second commonest induction agent after Propofol. It is essentially a barbiturate which works by suppressing the ACH neurotransmitter excitatory effect while enhancing the GABAergic inhibitory effect. One interesting history of the Thiopenthal was during the Japanese attack on the US bases at the Pearl Harbor. With reduced stocks of diethyl ether available as the commonly used induction agent during that time, intravenous sodium pentothal is a most sophisticated and complex drugs was used with devastating effects in many of those hypovolemic, anemic, and septic patients, causing the hazards of spinal anesthesia, and the effects were compounded by the lack of trained anesthetists during that time. Thiopenthal has an extreme rapid onset of action with the arm-to-brain circulation time of only roughly 30 seconds. Hence, it is often used as the rapid sequence induction agent of choice. The effect of Thiopenthal lasts within 3 to 8 minutes with quick awakening, largely due to the redistribution of the drug in the system rather than the metabolism of the medication itself. Its use is suitable in general anesthesia induction and has the advantages of lowering intracranial pressure, and is a potent anticonvulsant often used during status epilepticus when other measures have failed. However, Thiopenthal is a negative ionotrope causing marked myocardial depression as well as the quick build-up of metabolites. And about 30% of each injected dose will still remain in the body system after 24 hours, giving rise to the effect of hangover. Due to its extremely rapid onset of action, it is often unsuitable for maintenance. Besides, it has a very little analgesic effect and is contraindicated in the case of compromised airway and barbiturate allergy. One important risk to recognize with thiopenthal is the accidental extravasation injuries and intra-arterial injection causing arterial spasm, ischemia, and gangrene of the limb. However, this is less common nowadays due to the obligatory use of indwelling catheter. The next slide will show the immediate management of extravasation injury. First, stop the injection and aspirate as much drug as we can, but leave the cannula in situ. If feasible, mark the area of extravasation and elevate the limb, as well as consider other specific treatments if appropriate. It would be also wise to consider a referral to plastic surgery for any advice before we document the whole sequence of the events. Moving on, we have catamine as a dissociative intravenous induction agent, which is a phencyclidine derivative and functions as a NMDA receptor antagonist. It has a half-life of 2.2 hours, which is roughly equivalent to 130 minutes. With proven analgesic properties while having the advantages of causing little to no myocardial depression and the retention of protective airway reflexes. Hence, these properties permit its emergency use outside the hospital if absolutely necessary. On the other hand, it has the disadvantages of causing hypertonia and hypersalivation. One of the most feared complications of intramuscular catamine injection is laryngospasm causing airway obstruction. Other common side effects of catamine include delirium, hallucinations, and particularly nightmares afterwards. Ketamine increases the intracranial pressure, hence it is contraindicated in hypertensive patients. Etomide is the last intravenous anesthetic induction agent that we will be discussing today. It is a carboxylated imidazole, which is a kind of antifungal. Etomide has a half-life of 3.5 hours and does not provide any analgesic effect as compared to ketamine. It also functions by enhancing the GABAergic effect as seen in Propofol and Thiopenthal. Its use is limited to induction agent only, as long-term use in the case of critically ill patient may result in adrenal suppression with associated increase in the mortality rate. Etomide has a favorable cardiac safety, where its use is preferred in emergency settings where hemodynamic stability is paramount. Post-operative nausea and vomiting is one of the commonest side effects of Etomide, apart from involuntary mass movements and local thrombophlebitis post-injection. This is a summary table of the key points of each IV anesthetic induction agent.